It turns out that what many assume about addiction, that it is simply a matter of willpower or moral failing, is completely backwards. Addiction is a complex biopsychosocial phenomenon involving deep biological changes in the brain, intertwined with psychological and social factors.
Really? I mean, I knew addiction was complicated, but that deep biological change part always surprises people, doesn't it?
Yeah, it does. And it matters a lot because misunderstanding addiction leads to ineffective treatment, stigma, and missed opportunities for recovery, especially in healthcare settings where nurses play such a critical role.
So by the end of this episode, listeners will get a clearer picture of how addiction differs from compulsive behaviors, the neurobiology behind it, the Canadian epidemiological landscape, and how nursing approaches assessment and intervention, not just for patients, but for nurses themselves.
Exactly. It's a lot to cover, but it's essential for anyone working in this field to grasp these nuances.
Let's start with something that often confuses people: the difference between addiction and compulsive behaviors. How do you see that distinction?
Well, addiction is unique because it involves three intertwined elements: biological, psychological, and social. The biological part is key. It includes physical dependence and changes in both the central and peripheral nervous systems.
Right, so that means with addiction, the body actually adapts to the substance, leading to withdrawal symptoms if the substance is stopped.
Exactly. In contrast, compulsive behaviors, like gambling, gaming, excessive shopping, lack that biological dependency. They can be psychologically and socially damaging, sure, but they don't produce physical withdrawal or overdose risks.
That's a crucial distinction. I remember the example from the Vietnam War that really illustrates the social influence on addiction.
Yes, that's a classic. During the war, about 75% of soldiers tested positive for heroin use while in Vietnam. But when they returned home, only about a third continued using, and less than 10% were actually dependent.
So the environment played a huge role. Once removed from the life-threatening stressors, most stopped using.
Exactly. It shows addiction isn't just about the drug itself, but also the social context.
That raises an interesting question. Should essential biological drives like food or sex be labeled as addictions? Because those have biological components too.
That's a tough one. If we consider addiction treatment's primary goal is abstinence, labeling something essential for survival as an addiction complicates things. It challenges how we define addiction and approach treatment.
Yeah, it's a debate that's still ongoing in academic circles.
Moving on, the biopsychosocial model really helps us understand addiction's complexity. It's not just one factor, but a process involving biology, psychology, and social environment.
Right, and addiction develops through stages: no contact, experimentation, integrated use, excessive use, and finally, addiction.
Exactly. No contact means no use, obviously. And protective factors like culture, family, and fear of legal consequences can keep people there.
Then experimentation is when people try substances for various reasons: curiosity, peer pressure, stress relief.
Integrated use is interesting because some people use substances socially or culturally without negative consequences, like a glass of wine with dinner or cannabis before sleep.
But excessive use is when problems start: memory lapses, conflicts, risky behaviors.
And addiction is when physical and psychological dependence take over, with tolerance and withdrawal symptoms.
Speaking of biology, the neuroplastic changes in the brain are fascinating. The limbic system, especially the amygdala, and the mesolimbic dopamine pathway play central roles.
Yes, the ventral tegmental area to the nucleus accumbens pathway is often called the brain's reward system. Psychoactive drugs hijack this system, increasing dopamine release and reinforcing drug-taking behavior.
And the drugs mimic or alter neurotransmitters like dopamine, serotonin, GABA, endorphins, and endocannabinoids.
Right, and there are 5 main pharmacodynamic interactions: blocking reuptake, pushing neurotransmitters out, enhancing binding, blocking enzyme breakdown, and mimicking neurotransmitters.
For example, cocaine blocks the reuptake of dopamine, serotonin, and norepinephrine, increasing their levels in the synapse.
Exactly. Amphetamines push more neurotransmitters out of storage vesicles, enhancing the message.
And drugs like naloxone mimic neurotransmitters but block receptor activation, reversing opioid effects.
On the psychological side, learning theories explain how behaviors that bring pleasure or relief get repeated.
Personality traits like extroversion and impulsivity are linked to substance use. But personality alone doesn't predict addiction.
Psychodynamic theory suggests unresolved conflicts among the id, ego, and superego can lead to maladaptive coping like substance use.
And attachment theory frames addiction as an attempt to fill emotional voids from insecure childhood attachments.
Sociocultural factors are also huge. Culture shapes norms, attitudes, and availability of substances.
The 4 cultural patterns of alcohol use are interesting: abstinent, ambivalent, permissive, and ultra-permissive.
Canada fits into the permissive category, where alcohol use is acceptable but drunkenness is frowned upon.
Media and marketing also influence substance use trajectories, shaping perceptions and behaviors.
Now, looking at epidemiology in Canada, alcohol remains the most commonly used psychoactive substance.
About 78% of Canadians aged 15 and older consumed alcohol in the past year, with 21% exceeding low-risk drinking guidelines.
Tobacco use has declined dramatically, from nearly half of Canadians smoking in the 1960s to about 15% in 2017.
Cannabis use has increased, especially after legalization. Lifetime use is around 41% of adults.
Illicit drug use remains relatively low at about 3%, but opioid-related deaths have surged dramatically.
Over 19,000 opioid-related deaths were recorded between 2016 and 2020, with 1 in 6 being under 25 years old.
Indigenous populations are disproportionately affected, with hospitalization rates for substance-related disorders 4 to 7 times higher than non-Indigenous Canadians.
Concurrent disorders, where substance use coexists with mental health issues, affect about 1.2% of Canadians aged 15 to 64.
These individuals have worse outcomes and higher relapse rates, making integrated care essential.
Medical comorbidities are significant too. Chronic alcohol use can cause Wernicke's encephalopathy and Korsakoff syndrome due to thiamine deficiency.
Wernicke's is acute and reversible with thiamine treatment, but Korsakoff's is chronic with limited recovery.
Alcohol also causes liver diseases, pancreatitis, and increases risks for cancer, accidents, suicide, and homicide.
Fetal alcohol spectrum disorder is another devastating consequence, causing lifelong cognitive and behavioral impairments.
Injection drug use carries risks of HIV, hepatitis B and C, cellulitis, and endocarditis.
Psychiatric comorbidities like depression, anxiety, psychosis, and PTSD complicate treatment and increase relapse risk.
For clinical assessment, tools like the Michigan Alcoholism Screening Test and the CAGE questionnaire are widely used.
The CAGE is simple. 4 questions about cutting down, annoyance, guilt, and eye-openers. A score of 2 or more suggests clinical significance.
Withdrawal assessments include the Clinical Institute Withdrawal Assessment for Alcohol, or CIWAAR, which rates symptoms like nausea, tremor, sweats, anxiety, hallucinations, and orientation.
And for opioids, the Clinical Opiate Withdrawal Scale, or COWS, assesses pulse, sweating, restlessness, pupil size, gastrointestinal upset, tremor, yawning, anxiety, and gooseflesh.
Blood alcohol level correlates with intoxication, but tolerance can mask symptoms, making clinical assessment crucial.
Pharmacological treatments vary by substance. For alcohol, antidipsotropics like disulfiram cause aversive reactions, but are less used now due to risks.
Acamprosate helps stabilize the central nervous system and reduces withdrawal symptoms and relapse.
Naltrexone blocks opioid receptors, reducing alcohol cravings and the reinforcing effects.
Baclofen and topiramate show promise but have limitations like side effects and tolerance.
For opioids, methadone is a full agonist with a long half-life, reducing illicit use and withdrawal symptoms.
Suboxone combines buprenorphine, a partial agonist, with naloxone, an antagonist, making it safer with less sedation.
Naloxone alone is used to rapidly reverse opioid overdoses.
Nicotine replacement therapies include gum, lozenges, nasal spray, patches, and e-cigarettes.
E-cigarettes reduce exposure to carcinogens, but raise concerns about youth uptake and new nicotine users.
For stimulants like cocaine and methamphetamine, no approved pharmacological treatments exist, though some off-label use of modafinil and methylphenidate shows limited success.
Harm reduction strategies are vital. Needle exchange programs reduce blood-borne infections.
Supervised consumption sites provide safe environments for drug use, reduce overdoses, and connect users to health services.
Opioid substitution therapy with methadone or Suboxone maintenance reduces withdrawal and illicit use.
Heroin-assisted treatment is a secondary option for those unresponsive to standard therapies, involving supervised medical heroin administration.
Managed alcohol programs provide controlled alcohol doses with housing and health support for chronic users.
Psychological and nursing interventions include the trans-theoretical model of change, which outlines 6 stages from pre-contemplation to evaluation.
It recognizes ambivalence and gradual readiness for change, which is crucial in addiction treatment.
Motivational interviewing is a patient-centered counseling method to resolve ambivalence and enhance intrinsic motivation.
It involves steps like establishing rapport, setting the agenda, assessing readiness, sharpening focus, identifying ambivalence, eliciting self-motivating statements, handling resistance, and shifting focus.
Nursing communication techniques emphasize empathy, validation, reflective listening, and non-judgmental exploration.
Nursing care plans require comprehensive assessment of substance use history, medical and psychiatric comorbidities, social context, family history, and resilience.
Diagnoses might include risk for suicide, ineffective coping, impaired judgment, disturbed sleep, and social isolation.
The case studies in the material really humanize these concepts, like Kari, a nurse struggling with opioid and diamond hydronate misuse, helped by a colleague's intervention leading to recovery.
Or Bill, a young man with heroin overdose who re-engaged in methadone treatment through motivational support.
And Mr. Girtot Paso, a middle-aged man with alcohol dependence and depression, showing complex family dynamics and tolerance.
Nurses themselves are not immune to addiction. Signs in the workplace include frequent absences, volunteering for overtime near drug supplies, and discrepancies in narcotic counts.
There's an ethical responsibility to report impaired colleagues to protect patient safety.
Employee assistance programs and professional support exist, but stigma and fear often prevent nurses from seeking help.
Supportive policies aim to protect patients and help nurses recover and return to practice.
Relapse prevention and aftercare are ongoing processes. Relapse is not failure, but part of recovery, with lapses seen as learning opportunities.
Cognitive behavioral relapse prevention focuses on identifying triggers, enhancing coping skills, and managing high-risk situations.
The model distinguishes tonic factors, stable risk factors, and phasic factors, transient triggers that interact to influence relapse risk.
Aftercare programs with ongoing support improve long-term outcomes.
Mutual aid groups like Alcoholics Anonymous, Smart Recovery, and Women for Sobriety provide peer support but aren't one-size-fits-all.
Indigenous peoples face disproportionate substance use challenges linked to historical trauma.
Programs like One-to-Con Healing Lodge integrate cultural practices, smudging, talking circles, sweat lodges, with addiction treatment.
Affirmation circles and spiritual components foster healing and self-worth.
So to wrap up, addiction is a continuum with biological, psychological, and social components.
Assessment must be comprehensive and culturally sensitive.
Concurrent disorders complicate treatment and require integrated care.
Nurses must be self-aware and manage their own attitudes toward addiction.
Harm reduction and pharmacological treatments are essential components of care.
Motivational interviewing and the trans-theoretical model are effective frameworks for supporting change.
Relapse prevention is ongoing and multifaceted.
And nurses have a professional duty to identify and support colleagues with addiction.
It's a complex field, but understanding these layers helps us provide better care and support recovery.
Absolutely. It's about seeing the whole person, not just the addiction.
And that perspective makes all the difference.